Hi, welcome to Fertility Fact or Fiction, our weekly show where we try and bust all the myths and share all the truths with you about the wild world of infertility. I am Dr. Rahi Victory, a fertility specialist here in Canada, and we hopefully have an exciting show for you tonight, having a fertility coach with us. And we're going to speak with Crystal from Fertility Blooms, who has some interesting info to share with us about how a fertility coach can help impact your journey, and where they fit in and how they integrate into the journey for our patients. We've had a lot of attention from multiple fertility coaches lately who want to work with us. And so we're really excited about that. And Crystal expressed quite a bit of interest. And so we're bringing her on. We're actually going to bring on another fertility coach next week as well, because I will be on holidays, but we're still going to try and pull together a show for you. We'll see how that goes. If we can't do it next week, we'll do it the week after for sure. So welcome back. I hope you have all been well and everything's been going okay. And we hopefully will be able to get Crystal on shortly. We're just getting her linked on to the online portion of all this so that she can join us on the conversation. So in the meantime, not a ton has changed in the fertility world. There was an interesting new study coming out that I will hopefully share with you guys that actually questions the validity of the World Health Organization sperm criteria. That study looks at how long it actually took people to get pregnant using their, various semen analysis qualities. And the reflected number was much, much higher than what the World Health Organization specifies. So they're actually saying the numbers that the World Health Organization came out with are not all that accurate. We've always wondered about that because they never really made sense. So just to kind of give you guys an idea, the World Health Organization uses the count as 15 million per milliliter, which is definitely on the low side. It used to be 20 and then they dropped it down to 15. They use a motility percentage of 40%. They say at least 32% have to be moderately or rapidly progressive. And they say only 4% need to be normal in terms of their form. Those are really low numbers. I mean, I've always kind of been struck by the idea that only 4% of the sperm need to be normal because the abnormal sperm really don't bind or function. So you're automatically eliminating like 96% of the sample, which doesn't make a huge amount of logical sense to me, but the World Health Organization did their data based on how many people were able to conceive within a certain period of time. This new study, which is out, says that actually you need higher numbers if you're doing assisted reproductive technology. And even if you were just trying to get pregnant naturally, you actually also needed higher numbers than what they traditionally see as part of the World Health Organization numbers. So they were saying it will take you longer if your counts are at those threshold levels of where the WHO is. And this is something we discuss with all of our patients because we always spend the time to try and improve the sperm rather than throw people into treatments which aren't going to work. One of the really great studies that we reviewed internally recently is actually an older study which shows that if you incubate sperm overnight and less than 56% of the sperm swim, you have a very, very high chance of failure at IUI. So in other words, you keep the sperm incubating overnight and you wait and see what happens with the sperm. If by the next day, 24 hours later, the sperm is not, 56% of the sperm are not swimming, then your chances of success with IUI were literally negligible. It was like 3% or something like that. So we now have integrated that, into all of our sperm analyses where we incubate the sperm overnight and check it the next day, because we're screening out the people that aren't going to do well with IUI. Those people are basically wasting their money and there's no point in doing that. So these are things that are not captured in those standard numbers. And in the fertility world, a lot is based on numbers, right? So people are always wondering, what's my percentage of this? What's my percentage of that? What's my chance of this? What's my chance of that? So having these strict criteria by the World Health Organization, everyone kind of figures, oh, well, my sperm count was fine, so I'm okay. But the reality is you've got to look at that total sperm picture. It's not just the count or just the motility. It's how many are normal? What's the DNA fragmentation like? How many of them do survive overnight and swim the next day? What is your count like? So all of these things are really, really critical. So these were all really important pieces of the puzzle. It appears that we're having a little bit of trouble getting Crystal to log on. Can we send her another link maybe, or would it work from what now since we're on? Can you hear us, Crystal? I think we can hear you. Yeah. Can you see the picture? Is she up on the screen? Okay, so welcome Crystal from Fertility Blooms in Canada. And she's on Fertility Blooms.
I can't hear you.
You can't, or you can? Can you see the picture? No, she still can't hear us. Okay, we're going to work on that for a minute. So we can hear her now, but she cannot hear us. So we will keep chatting. So you guys can start asking your questions.
It's delayed.
In the event that we can't coordinate everything with Crystal.
I can hear.
Try and get this all perfected. In terms of our own things that we're doing here, we are, for those of you that are wondering, still working hard on getting government funding. I am still very hopeful that we will, but we have not heard anything official yet. So those of you who can, reach out to your politicians locally and see what we can arrange. I'm meeting with another politician soon to try and help promote this and get this up and running for everybody, because we do need this region represented and we are not represented. So I think Tarek's just signaling that Crystal is okay now. So Crystal, can you hear us? Just let us know if you can hear us. Crystal, can you hear us? Just wave hello if you can hear us. Nope. Okay, we're still working on that then. So why don't you guys ask some questions? Are there any there? I need one of the two phones. Give me yours or give me mine, and I'll work on it from there.
Okay. I can read them to you.
Oh yeah, you can read them to me. That's good. Then you can keep Crystal and tell me what's going on. So Crystal, we're going to keep working on getting you involved. I'm not sure if you can hear us or not, but we are trying to connect. For some reason, it's not working. I don't know if she can.
I have PCOS with what is the optimal TSH for IVF medication required?
So if you have PCOS, medication is usually required. There are three things you have to do for PCOS. So one is to use medication, which is usually metformin and letrozole. Two is to use vitamins and supplements. So it's inositol, NAC, NAC, and to use coenzyme Q10. And then the third part of it is to do lifestyle measures. So if you're in the not thin category of PCOS, you have to use, sort of weight management and exercise. And you have to use all three of those. From a thyroid perspective, you want your TSH less than 2.5. So if you're over 2.5, you do need to go on thyroid supplementation. And even if you're less than 2.5, you need to make sure that you don't have antibodies. If you have antibodies, then get your T4 checked. And if your T4 is in the normal range, you can tweak your TSH by taking some extra thyroid hormone, which should help facilitate making your antibody level go down without jeopardizing miscarriage risks or anything like that in the pregnancy. So there are a lot of things you can do with PCOS. Whether or not you have thyroid with PCO is a different story. Not everybody with PCO has thyroid issues. And certainly not everybody with thyroid issues has PCO, but they do come hand in hand sometimes. So it's good to get checked. Okay, so we do have Crystal, we think. Crystal, can you hear us? No? Yeah, just ask another question. We'll have to maybe reschedule Crystal. For some reason, she's having trouble connecting.
I can hear you.
Oh, good. Okay, Crystal can hear us.
Oh
so
God, I don't know what happened.
You can hear us now?
Yes, I can hear you now.
Excellent. Okay, so
Oh
welcome,
my God.
Crystal.
I have no idea.
Finally, no problem. Welcome, Crystal from Fertility Bloom. So Crystal is a really interesting lady who has a personal history in the infertility world and decided she wanted to try and make it better for everybody by helping people through their journey. And she wanted to do this kind of in a more formal fashion. So there's no doubt if you're on Instagram or any social media platform, there are literally hundreds, if not thousands of people that are fertility coaches. And I kind of wanted to know a little bit more about this. So we were contacted by several fertility coaches, and it's been really amazing talking to them. And so we wanted to bring some on to see what you guys thought and have a chat with them and see what they offer and how it integrates into your journey. So welcome, Crystal. Thank you for joining us tonight.
Thank you so much for having me. Sorry about for all the technical confusion. I'm not sure what was going on, but yeah, thank you so much for having me.
Oh, my pleasure.
I think it's really fertility. I never liked the word coach originally because I feel like everybody calls themselves a coach of everything nowadays. But now I see the importance of it and I just love it. And now I've embraced the word. So yeah. Especially now that the Olympics are on.
That's definitely one of the more common terms we see out there when you're searching. There's, everybody out there that promotes themselves in this vein is always saying that they are a fertility coach. So it's a pretty common thing that we're seeing. And I think some people kind of do it on the side, but not as many people have kind of turned it into as big of a process as you have. We've met with a couple that have, and so we're hoping to, kind of share you guys with all the patients out there, because I do think that they can derive a lot of benefit in certain circumstances from this kind of activity or relationship. So tell me a little bit about exactly what sort of services a fertility coach provides.
Okay, so first, like you said, there's tons of fertility coaches. So some like really niche down and focus on, say, nutrition or various things like movement and exercise and weight loss and different things like that. For me personally, I kind of put all the pieces together of what I thought I was missing when I started my journey. So when I started my journey, there wasn't really anybody out there that was doing a little bit of everything. There was no support. You have limited time as a doctor to explain what's happening, right? So then the patient goes to Dr. Google and asks tons of questions, and they don't know what's true, what's not. Then they go on the crazy Facebook groups, which I always say not to do, and they get more information, and then they're overwhelmed. So I try to put all the missing pieces together. So I work on mindset, which I feel is a big missing part. I work on some nutrition. I work on like movement, physical activity, blood flow kind of thing, stress levels, everything. And I look at everything. So they'll get a diagnosis from their doctor. And then I kind of see what's missing and how can we optimize their fertility and make their journey a little smoother. So yeah, that's how I work.
That's pretty amazing. So kind of a very holistic approach to the whole process.
Yeah.
Now, do you sometimes help patients with their initial consultations as well? Because I know that's like a time where a lot of people don't necessarily, there's a lot of fear, there's anxiety, they've waited months, and then all of a sudden their mind goes blank and they don't remember what to ask. So do you ever get involved in that part of it as well?
All the time. Before I would do more in person, But now with virtual, it's awesome. So I can go anywhere. And I'll sit on the calls, whether it be initial visits or even like throughout their journey, I'll go on the calls with them. And what happens is a lot of like the overwhelm and the anxiety kicks in, and they might not know the questions. So anybody that works with me, I give them a list of about 15 questions to ask, but they still might feel like nervous asking those questions or feel overwhelmed. Or even if they ask the questions, whatever you tell them, they're so nervous and full of anxiety, it just like, they forget it. So how I work is we kind of do like a little pre-meeting, and then we meet with the doctor. And then after, we go over the options and whatever he said or she said, and we kind of go through and do what feels right for them, so they kind of understand more. And
what part of that do you think patients find the most useful? Are there specific questions that you offer that seem to be like a consistent theme that we should do a better job at addressing, or is it always different for each patient?
Well, I kind of tailor it when I'm working with somebody. I kind of tailor it to what they need. But like some of like, say the top 3 questions I always tell people to ask is always like, ask if they'll be like, will they be seeing you, Dr. Victory, or are they going to be bounced around to different physicians? Because that happens a lot, right?
Right.
And sometimes they never even meet their doctor. They're just whatever, bounced around and dealing with the nurses and different things like that. So that's one. Who will they be seeing? I always ask if there's an emergency contact, like for after hours, if they have questions, or on holidays, how that works around the holidays and things like that. Because I know my first miscarriage, it was December 18th, and they told me to come back in a week to see if there was a heartbeat. And then the girl goes, oh, wait, that's Christmas. So can you just try to figure it out in between Christmas and New Year's? And I was like, what do you mean there's no heartbeat? Like I was so baffled by the whole process that having a contact person or access to the doctor or somebody that knows your case after hours or emergency situations, I think is really important. And then another thing is when they'll be coming into the clinic, like how many days, because there's so many variants. Like, is it day 3? Is it day 10? Is it like all of the days? Is it every second day? What's the process for that doctor? Because each doctor has a different process. So then they know what to expect. Because when you're going in, you don't realize you have to be at the clinic a lot.
Do you think patients are kind of oblivious to those facts, or are we not doing a good enough job kind of relaying that to them?
I don't know. I think when you first start out on your fertility journey, you don't, like, everything seems so new. Like, a lot of people don't even understand, like, okay, there's no heartbeat. What does that mean? Will there be a heartbeat like in several weeks? Or what does that mean? What are your beta levels looking like? What are you checking? Like, what's the blood work? What are you checking for in the blood work? Like, it's all so new. They don't know even the 101s, right?
Yeah.
And I get it, because you won't have all that time to explain everything. So
yeah, I can say for us that we actually have just me here. Sometimes the patients will see Dr. Mayran before they get to me. But they actually end up with me in terms of decision making and so on. And we're kind of integrating with another one of my practice partners, hopefully soon. So we are going to start to kind of integrate some patient steps, but I think we're going to kind of separate it into, if you want this, you go here, and if you want that, you kind of go there. And we do have a hotline, so I'm really happy about that. We have for a very long time. So I think that's a huge benefit for the patients, because they can reach us. And actually, I've had loads of patients just reach out to me. Even people that aren't my patients reach out to me on Instagram when they're desperate because their own physician isn't answering. I can't even tell you how many times I've answered questions for other doctors in other parts of the world, just because those doctors aren't making themselves available. So we're pretty available for the patients. So that part's great.
That's, you know what, that's what happens. I get so many, like, can you get a hold of my doctor? Can you help me with this question? And it's even something as simple the other day is she was supposed to start her gonal, and they didn't even tell her how much.
Oh my
So
gosh.
what she did is she took I think she might be listening to. She took what she did the previous month because she left a message. She sent an email to the clinic. They didn't get back to her until the next day. And they said, oh yeah, that's the right amount. And she's like, thank goodness that I just followed my gut instinct because they didn't tell me. They just said, start the gonal tonight. So
yeah,
that's happening.
we solved that problem pretty quickly by we don't make those kinds of mistakes, but we actually have a hotline number. And then after a certain hour, the calls actually go directly to me. So we have an emergency number and the patients are all given that. And that way, if there is a glitch, they can reach me and I always answer. So the answering service will get a hold of us. And, we've come back to provide people with meds that they didn't realize they didn't have, or, to do a blood test, or even to organize treatment and whatnot. So I think you're right. Like those sorts of things are really critical. And it's amazing you point out that that's something you talk to patients about, because I've actually never had a patient ask us if we have those sorts of things. So no one ever said, am I going to just see you, Dr. Victory, or do you have a hotline? So those are really good points.
But I told you, you're doing things so different. Like I've said, I wish you were my doctor at the start, because all the missing links that I see, you're like, oh, we do that. And it makes a big difference because not every clinic's doing that. And I talk to clinics all the time and they're missing those critical things that just make it easier for the patient. Because I always find they're already under so much stress and the whole process is overwhelming that just those little details just like helps like ease their anxieties over everything. So, yeah.
What kind of patients do you think benefit the most from having a fertility coach?
I work with two kinds of types. I deal with like me, type A, full control, and then they feel so frustrated because you realize in the fertility journey, you have no control. So the only thing we can control is what we're doing and how we're optimizing our fertility and our minds and making sure that we're at peace at that and giving us our best chance to have the baby.
Sure.
So I deal with that. And then the second type is I deal with people that have lost all confidence in their body. So they've had miscarriages, they've had failed IUIs, transfers, IVFs, you name it. And they just think that it will never happen. So I really work on the mindset piece for both of those scales. The type A to bring them down, to like help them like get into control, even though they're not in control. I always say, let go to get the control. And then the other side of it is to give that person the confidence and to know that her body is okay and that there's a way through this journey. And I even help people like when the end road is maybe like an egg donor or surrogacy, and I help them all the way through all those kind of things. So, because I always say the goal's the baby, right?
So do you offer this in terms of like packages of treatments, or is it just kind of hourly? Like, how do you work this out with the patients that want to work with you?
So for me, I have two like programs. So I have the, it's called the Fertility Blooms Method. And I put that together in 90 days because I really think that our bodies can make adjustments in 90 days. So for men's health, for men's sperm, you can see improvements when you change like the diet and the supplements and you name it, right? Like
for sure.
Physical exercise, things like that. And then mindset. And then for the woman also, her egg quality and stuff like that changes. So I do a 90-day program, which is intense. We do everything from a lot of mindset stuff, relaxation, diet. We go through the whole gamut. There's sleep patterns, everything. They have exercises and homework to do all the time. And then I may give them like, okay, I suggest that you see a naturopath or acupuncture or different modalities that they might be missing that might help optimize their fertility a little more. So that's my 90-day package.
Okay.
Then I have a package that's 6 weeks. And that's like kind of just like the Cole's Notes. If anybody knows what's Cole's Notes, I'm dating myself now. But the Coles Notes version of it, and it kind of goes through the mindset, relaxation techniques, things to make you feel in control. Things like we'll work with, like, what are you going to say to the doctor or ask the doctor? What I always do is you'll give them the options, right, of where they're at, and then I'll go through it with them, see what they've been through, and we kind of go from there. So work on stress reduction, physical activity, and then diet, I think, is a really important key. And then I do a lot of one-on-one sessions that are just like an hour or 90 minutes. And soon, hopefully this fall, well, not hopefully, we will have it set up this fall, because I deal with a lot of girls with PCOS. So I have a friend that's a homeopath and nurse, and we're developing a PCOS package as well. So
awesome.
We're just kind of shaping that, and just specifically for PCOS, because that's my other chunk, is mostly PCOS ladies. So yeah.
Amazing.
Yeah.
So what's the easiest way for patients to contact you if that's something that they're interested in doing? How do they get a hold of you?
What I do, I'm like you, everywhere on Instagram or Facebook. So what I always say is book a free session. The link in my bio on Instagram, you can book a session right there. It's 25 minutes. I kind of look at where you've been and move you forward and see what kind of steps we could do. And if it's a good fit, we can figure out the best program for them. So that's probably the easiest way. So I always offer the free 25-minute consultation. Often I'm sure you do this too, it runs way longer. But my goal is to help people. When I started my journey, I felt so alone that was like the most important thing for me, is to make sure other people get just the support and the answers, because sometimes they're just so lost and so feel so alone that's like, my most important thing.
So I just want to take a chance to say to our audience that if you have questions for Crystal or myself, don't hesitate. You can start asking now, and that way we'll be able to join with Crystal in answering those questions for you guys. I guess one last question I'd ask is, what sort of cost can patients anticipate from something like this? And it doesn't have to be specific, but kind of a range of costs for what services you offer, and what's average in terms of what people would need to invest into this to have that extra level of comfort and care, having kind of a fertility partner and coach along the journey with them.
Yeah, and that's what I like the word partner better than coach, but so for an hour, I bill at $125, and then 90 minutes is $175 an hour. Okay. And then we do the program. So the 6 weeks is $650, and the 90-day program is $2,000.
Okay.
Yeah, so that's what we're looking at. And then with the 90-day program, they get sessions each week with me, so every week. And then they get big 90-minute sessions each month of that program, as well as with the 6-week program. They get a 90-minute call and then touch base and stuff like that. So you're not just left on your own to do the homework and things like that.
And do you have a limit on the number of patients you take per month, or it's kind of sky's the limit, you can handle whatever they throw your way?
Yeah, for right now, because the way the programs work, everybody can join at different times. So I'm really flexible like that.
Okay.
So it's not limited to a certain number as of right now. And I should mention, I offer also a support group once a month. That's on Zoom. That's awesome. Yeah, it's the first Wednesday of every month. And we get now, before we used to do them in person. And when COVID hit, it was like kind of sad because you didn't get the interaction. But now we get people all over. Like, I think she was trying to get on tonight, but she calls in from the UK. So it's always like 1 a.m. for her.
It's
we have
2:30 in the morning now. So hopefully not trying to get on.
But we have people like all over the US and Canada. And it's nice to hear different perspectives on what goes on at each clinic and how people are interacting and things like that. So,
Yeah, it's
and that's
interesting
free.
you mention
There's no charge.
I get a lot of clients contacting me from the UK, and the fertility care there seems to be terrible. So
it does, right?
it's not a shock to hear somebody else echo that as well.
Yeah.
Let me see if there's any questions. Do we have any questions targeted at myself or Crystal regarding this stuff? Or
So far, muted.
Nothing targeted, eh?
Nothing targeted.
Okay. Well, thank you so much for joining us.
Thank you for having me.
Our audience likes to monopolize our time with all their detailed questions on actual like numbers and what the chances are for this, that, and the other thing. So we'll kind of build in parts of what you can offer during that discussion tonight. But thank you so much for joining us.
Thank you so
it's
much.
Always a pleasure. I love your personality and your attitude.
I know.
So I think we're going to definitely be sending some people your way when they need that extra TLC.
Thank you. And I forgot to mention, we also have a Facebook group, because I mentioned movement and exercise. So right now, anybody can join this. It's free. And we do a step. So they have to do their steps and they have to drink a smoothie every day. And each month we kind of do different activities like that. So anybody's welcome to join those challenges and stuff like that, because it kind of builds up your teamwork and everybody's in it together. So
awesome.
Yeah, thank you so much for having me again, and we'll talk to you soon. Bye,
All right,
everybody.
sounds good. Thanks for joining us, Crystal. Have a great night.
You too. Bye-bye.
Take care. Bye. Okay, so thank you to Crystal at Fertility Blooms for joining us on the show tonight and being patient while we worked out the notorious technical glitches of using the software that we use. So I think we have some other questions, I'm assuming, so fire away.
Can you take DHEA if you have PCOS?
Oh, that's a great question. So there's a guy in the US, I forget where he is, I think he's at Case Western, that swears that you should take DHEA if you have PCOS because you actually need it to improve things. They were doing a study, I never saw the results, and I don't know if they were published. So I'm not sure if they weren't published because it wasn't what they expected it to be, or it just didn't make it, or they never did the study. But there is a guy that swears by it. I've never tried it. Women with PCOS already have androgen excess. Giving them more androgen doesn't make a ton of sense. But this guy swore that there was some hormonal linkage that made it, acceptable. So there's no reason why you can't. But whether or not it's helpful, we don't actually know. There's no evidence that supports the idea that DHEA improves outcomes in women with PCOS. But you can take it. It's just a matter of why would you? You already have high androgens. Why would you take more? I think their argument was that by taking it, you suppress some of the PCOS symptomatology, but you're kind of replacing one thing for another. I'm not sure it actually makes a difference. So I don't get the biology behind their claim, but they swear by it. So it's doable. I just don't understand why you would.
I've been spawning 5 days post-ovulation. This happens a few times. I think the last year. I'll be starting IVF with you in 2 weeks. Is this something I should be concerned about?
So it could be hormonal, or it could be that there is a polyp or something inside your uterus. If you're with us, we've already done a saline infusion on a histogram. If you had a polyp, we would have seen it. If it's truly persistent, especially after your IVF cycle, before your frozen embryo transfer, we'd probably pop a camera in there to look around. But it would be interesting to see how you are during this medicated, stimulated cycle, because if you don't spot after we do your trigger, then you probably will not have a problem when we're doing a frozen embryo transfer either. So it's a great question, but it's a matter of what you're like when you're on the meds that we use, as opposed to just being natural.
Can immature eggs mature in the lab?
Yes. In fact, I have one patient who I believe has what's called an FSH receptor mutation. She is totally resistant to all the gonadotropins. And so we're actually going to harvest her eggs when they're really early and mature them in the lab. Is it as good as what you get when you have normal eggs? No. So about probably 8 or 9 years ago, 10 years ago, there was this huge movement in the PCOS world before we figured out how to do triggering with the GnRH agonist to retrieve women with PCOS when their eggs were very small, immature, and then mature them in the lab. And in particular, there was a center in Montreal here in Canada that swore that this was the future, and they had these great results. I mean, nobody is doing this if they can avoid it. It actually does not result in good outcomes at all. So can you? Yes. But do we want to do that? We want to do that as little as possible. So egg maturity is a huge issue. If you get them at the right time, they're great. If you get them too early, it definitely does not give you the same outcomes you want. And if you get them when they're post-mature, so you've let them grow too long, there's loads of centers in Toronto that, for example, don't even retrieve every day. They retrieve when it's convenient for them. You can't run an IVF center retrieving when it's convenient for you. You got to retrieve when it's right for the biology. So they're waiting till the eggs are 23 millimeters, 24 millimeters. All those eggs are post-mature. None of them are going to work well. So we do sometimes need to hedge our bets a little, and I'll let someone go a little longer in order to get enough eggs that are reasonable. But by and large, you want to retrieve eggs precisely at the right time. And typically that's around the 11-day mark, plus or minus maximum 1 or 2 days. And roughly when they're about 18, 19, 20 millimeters, again, plus or minus a little bit. So, that's what we're generally aiming for. Can we mature them in the lab? Yes. Do we mature them in the lab all the time? Should you? As little as humanly possible. You're only doing it when, you've got eggs there that are immature, but you think are close enough to mature. And then if you're actually doing the complete in vitro maturation, IVM, that requires a whole other approach. You actually have to add certain ingredients into the culture media, including gonal F, to get those eggs to grow. So it's a whole other kind of approach to things.
We asked the question on the poll right now. Do you like us to host more guests on the show?
Oh, yeah.
If you want to just vocalize that.
Vocalize that. Sure. Yeah. So on the screen, you'll be able to see a poll that says, do you want us to have more guests, or are you more interested in me just kind of reviewing a topic and answering questions? So let us know. Click on that poll and give us some info, because that's always super helpful for us in designing what we're going to do next.
Is there waiting for IVF in Windsor? If yes, how long? And is there any government funds available in Windsor for IVF?
There are no government funds available in Windsor for IVF yet, but as I mentioned earlier in the show, we're working really, really hard on getting that, and I am hopeful that it will come through. So yay, Mr. Ford, Premier Ford, and his government. And how long is the wait? There's no wait. If you're paying for it, we don't have a limit, so we can accommodate as many people as want. To join, we do need your investigations and your tests, and we will not proceed unless you're ready. So if you show up here and we have terrible hormones and your thyroid's out of whack and your BMI is sky high and his sperm is terrible, I'm not going to let you do it, because I don't believe in doing it when things are not optimized, because that's me taking your money and not helping you, and I just won't do that. So we make sure you're right before we start, or we don't do it.
The poll is interesting.
Tarek's having too much fun with the poll.
Yeah. I hope Pete lasts.
That came out sounding so bad.
It gives you the courtesy of asking questions.
Go ahead.
I hold Pete last. I have 7 weeks. I just start pain in my back. Is that normal?
I hold P last?
Hmm.
I just started having pain in my back?
Yeah.
I'm not sure what that question means, but if you hold your pee for a very long time, it is not good for your kidneys. So don't do that. It's terrible for you, actually. So don't hold your pee too long. That's an interesting question on our show. But don't hold your pee. It's bad for your kidneys. It causes it to back up. It also distends your bladder and has all sorts of complications. So don't get a doctor's bladder. It's awful. I got kidney stones. Yeah.
Dr. Victory, how much weight do you recommend after a MC? I just had my first miscarriage. I'm not sure when I should start next. My spouse also had borderline sperm results. so don't want to rush.
Sure. Okay, so two separate parts to that question. The part in regards to your body, you don't have to wait. That's actually been studied. It was a few years ago in what we call the Green Journal, which is just called Obstetrics and Gynecology. And they demonstrated that there is no need to wait between a miscarriage and another conception. You can literally try the next month with no harm, no risk, and no change in outcome. With regards to your husband, if he has borderline sperm, you definitely want to do everything possible to improve his sperm, because men with poor quality sperm, especially if the DNA fragmentation index is really elevated, they actually have a much higher chance of miscarriage, 1,183% higher. So it's like dramatic. So if your hubby's sperm is not good, you need to correct his sperm before you try getting pregnant again. Otherwise, you're putting yourself at risk for another miscarriage, which is why when we're doing IVF, we don't just plow people through the IVF machine, or IUI for that matter. I make sure I optimize things for people before I let them start, because a couple of months delay is not going to make a change to your fertility, but it's going to make a change to your outcome, and you're going to have a much higher chance of success, and it'll be more financially efficient for you. I don't want to take people's money if I'm not helping them. That's just, to me, dishonest. So most other centers will just say, yeah, come on, let's do IVF, you're ready to go. But we don't do it unless everything's optimized. Do I make less? Yes. But can I go to sleep at night knowing I'm an honest guy? Definitely. So, that's the way we operate here.
Are IVF babies more likely to have childhood cancer? I also read that IVF babies are more likely to have heart defects. Are there any more tests performed at the anatomy scan to check this?
So there's no evidence that IVF babies have more heart defects. There's a whole batch of literature about whether IVF children have a higher risk of malignancy. The jury is out. There are studies that say yes, and there are studies that say no. There was a recent one that just said no. Prior to that, there was one that said yes. So we don't know. It doesn't really make sense that IVF children would have more malignancies, and we certainly haven't seen that in our practice. But, God forbid, children are at risk of malignancies like any of the rest of us. So it's devastating when they get it, and we all want to do everything we can to help. But IVF does not appear to increase those risks, at least not based on the data we have so far. But it is being looked at very carefully over and over and over again. And it's one of those, back and forth kind of things. I feel like I'm on a teeter-totter seesaw. They go back and forth all the time. No one knows for sure. Good question.
Doing my first FET this week.
Yes.
Any advice for the days leading up to it and anything I should do in the weeks that follow? Should I stop high-intensity exercise and stick to walks?
You should stop high-intensity exercise and stick to walks. Do anything that de-stresses you. Don't do anything that stresses you. No smoking, no drinking, no drug use. Avoid extremes of everything: sugar, cholesterol, salt, fat, heat, cold. Anything like that at all, spice probably even. And just kind of live as healthy as you can. You want to be as tranquil as possible. That doesn't mean kind of sit there like that scene from Mrs. Doubtfire, but at the same time, you want to, be reasonable about the activities you do. Is it the right time to do HIIT training? No, it's totally the wrong time to do HIIT training. Remember, when you're doing that kind of intense exercise, your blood flow is being drawn away from your uterus and going to your muscles to help provide the muscles with the oxygen they need. That's the wrong thing to be doing when you're trying to get pregnant. So cool down a little bit.
The poll is tied.
Oh, the poll is tied.
Tell everyone to do it.
Okay, everybody's got to get on. We got a tied poll, so you all got to jump on there and give us something. And it's on YouTube, so jump on the YouTube channel. Yeah.
Great question.
Okay.
How does night shift work affect fertility, as I am a man, and how can I improve my sleep when I have 2 night shifts a week?
Ooh. So that's a great question. There are changes in your circadian rhythm when you do night shifts, which have hormonal alterations which can impact both male and female fertility. I'm not sure that there's a way around that, considering you've got to be up 2 nights a week. So I'd probably say take melatonin during the other days so you're getting a good night's sleep. You don't have a choice. The only thing you could try to do is either change kind of your work shift, if that's possible, at least for a little while, and then free some sperm from better samples. Or you basically just kind of want to live as healthy as you can, take as many vitamins as you can, ejaculate every 2 days, keep the testicles cool, and just see what kind of quality you get. But that's a tough one because you're kind of jammed in where you're working to doing what they're telling you to do. So it does make it harder. There's no question. I'm sorry you have to go through that, but there's no easy fix for that one. You just got to try.
So we had a question on YouTube that was asked for your double IUI video, and they were asking that in another video that you had mentioned, you need to trigger if you ovulate. So there's some confusion over IUIs and double IUIs and double triggers.
Okay. So a double trigger and double IUI have nothing to do with one another. So a long time ago, probably 2 years ago, we reviewed an article that said that it is better to not trigger people who are naturally ovulating than to trigger them with monitoring, because you get a better success rate by not triggering them than you would with triggering. So we actually stopped for, 6 months or so, 4 months, 6 months. And we let everybody naturally surge, and then we would do their IUI based on their natural surge. We actually saw a huge decrease in our success rates. So we analyze our rates all the time to try and improve constantly. We have quality control meeting every month. And at that meeting, we said, yeah, this isn't working. We're going back to the old way. So we have kind of abandoned that now. Now, as far as a double IUI, we only do if the patient pleads with us to do it, or they have very, very, very poor sperm where we feel that, and they're insisting on doing IUI, where we feel that a second batch of sperm might somehow help. But in general, there are multiple randomized controlled trials which demonstrate no benefit to a double IUI. Now, a double trigger is using a GnRH agonist with HCG as your trigger. So that has been proven in multiple studies to improve your outcomes. So that's using 2 triggers at the same time to affect the ovulation, but it has nothing to do with doing a double IUI. It's not like you do 1 trigger here and 1 trigger there, and then you're doing 2 IUIs. It's 2 triggers at the same time. And then if you want to do a double IUI, you do either 1 or you do 2 kind of close together. But those are 2 totally separate issues. So a double trigger is doing a Lupron or any kind of GnRH agonist with a small amount of HCG.
That's what I thought. What are the benefits for the child later in life if I follow perfect fertility lifestyle as a man for 3 months before conceiving, even when I can impregnate my wife without it? Is it worth it?
Yeah, so I'll give you the best example I can. If you're a smoker and you conceive a child while you're smoking, your child grows up to have higher risks of heart disease and cancer because you make epigenetic changes on the DNA of your sperm, which go into the child, which predispose the child to complications. So that's a huge issue. Alcohol increases the risk of cardiac defects in children, so huge issue. Marijuana is a nightmare, don't do it. Increased risk of miscarriage, increased risk of behavioral problems in the child, psychological problems in the child. It's like a long laundry list. So your lifestyle factors have a huge impact. The weaker your sperm is, the higher the chance that your child will also suffer from infertility as well. So there are a number of reasons why you should improve your sperm before you get into a type of treatment or cycle or even natural conception. So that's a great question. No one's ever asked us that before. Thumbs up for you, man. Good job. All those little floating hearts that go up the screen or whatever.
He deserves it.
He deserves it.
From 16 fertilized, we sent 8 days 5 and 2 days 6 blasts for PGTA last week.
Wow.
38 years old,
Okay.
unexplained other than age.
Okay.
How many would you expect to come back as euploid?
Roughly 65 65, 66%. Maybe a little bit higher or lower, but that's the average for that age range. So 2/3 of your embryos should be genetically not normal. 1/3 should be okay. So if you sent 8 and 5, right?
8 and 5.
So 13. So you'd expect to get back about 4, maybe 5 of them being normal, and the rest should be abnormal.
When should I start with baby aspirin before I FET? And when should I stop?
Don't stop until you deliver your baby, and start anywhere from a couple of days to a couple of weeks before. We don't know when you're supposed to start, but I always start it before. I think that's really important. So most of our patients start when they start their stim on day 1 of their cycle.
Hello, Dr. Victory. I had FET 5 weeks ago, and we were able to see the heartbeat last week.
Awesome.
Everything looked good, except there was a little bit of bleeding.
Okay.
Is a 3 to 4 hour road trip okay? Thanks.
Oh, yeah, it's probably okay. Just not somewhere bumpy. And as long as you're comfortable, and plan to stop and pee, because pregnant women pee constantly. So it's a long road trip. But as long as you can handle it and it's not a big bumpy ride, yeah, you're probably fine. That's not a problem.
This is an inspiration for your next video, this question.
Okay.
What is the perfect diet for males to boost fertility? And what are the top 5 fertility boosting foods and supplements?
Whoa. So we need Jen Strong for that one. Jen, if you're watching, why don't you post the answer for that one, honey? Because that's a you question. Okay, Mediterranean diet has been proven to be beneficial. So that's a diet that's rich in grains, fresh fruits and vegetables, low in meat, a little bit of fish, super low in sugar and cholesterol and fatty foods and stuff like that. Vitamins, you want lots of vitamins. So there's male fertility vitamins. All of the antioxidants are really critical. So that's important too. If you can't get them from the foods you're eating, you want to get them from an actual vitamin in a pill. On top of that, what are the top 5 foods that are beneficial? Wow. So probably anything with a lot of antioxidants in it. So most fruits are going to be very beneficial. I got to drop down, go up. So most fruits are going to be really beneficial and have lots of benefits in that regard. So vitamin C from citrus, A and B from any other vegetables that you're eating, carrots and that kind of thing. Tomatoes have lycopene. So that's a reasonable approach to thing. I mean, any kind of fruit veggie approach is going to help you. So that's basically what you want to have: salad and fruit salad for all intents and purposes. And then whole grains are healthy, kind of a paleo type diet. And of course, it depends on you, right? So if you're super slim, you may need some extra protein. If you, or maybe even some extra fat. If you are average, then have an average diet. And if you're heavy, then you need to cut back on calories. So you want to get rid of your sugar and your carbs and your cholesterol. So yeah, it depends on what your body habitus is like. Yeah.
My GP has faxed you the referral for my case, wondering, Dr. Berry, how long it'll take you to get a first consult with you.
Anywhere from a couple of weeks, depending on how urgent it is, up to a couple of months, depending on how not urgent it is. So if it's urgent and they marked it as such, we'll see you pretty quickly. If you feel it's super urgent, then you can always DM me and I'll see what I can do. But it is up to the office staff who triage everybody. And obviously we have lots of people that have been waiting. So I can't kind of kick people that have been waiting out of line to make space for others just because they feel it's urgent when it actually isn't. But we do our best to accommodate everybody. And most of you that have watched me or know me know that I work kind of 24/7. So there's always opportunities.
Have you seen cases where young women less than 32 with above average AMH 4.3 nanograms per milliliter have poor egg quality? What can cause this?
Have I? Yes. Overweight can cause that, excessive weight, bad diet, low vitamin intake, smoking, drinking, drug use. Those are definitely huge causes. Genetics can cause that. If there's any kind of systemic inflammation or irritation, endometriosis, that can cause bad egg quality. So there's a lot of factors. I mean, that's a big, long essay on all the different things that could contribute to it. So yes, it is possible. I guess the first thing I would ask is how they figured out you had poor egg quality, because sometimes the lab is not great and then they blame it on your eggs, but in reality, it's not your eggs, it's the lab. So, you know, the best measure of that kind of thing is how well the lab is doing for you. I'm so proud. Yesterday was World Embryology Day. I am so incredibly honored to work with Dr. Fariba Khosravi, our lab director. She is absolutely spectacular. Time after time, I give her, you know, 5, 6 eggs, 10 eggs, whatever it is, and she gives us back an equal number of blastocyst embryos. 2 cases today, she gave me one. There was just 1 egg that didn't turn into a blastocyst. The other one, all of them, 100% turned into blastocysts. This is a routine outcome at our clinic now. I'd love to say it's all me, but I can't take credit for it. We know what we're doing, and my team is amazing, and we do a good job. But Dr. Khosravi and Staffy Christian, our junior embryologist, are phenomenal. In that lab, we invest so much money into getting the best of everything in there. You know, we make sure it's always top notch. And right now the air quality is amazing and the incubators are incredible. We just got a brand new incubator again. We replaced one that was only a year old with an even better one. So we're really always moving this forward as aggressively as we can to stay at the very front line of the tech and of the lab element of this. And Dr. Khosravi just does better than anyone I've heard of. No one is getting 100% blastulation. My last embryologist kept telling us that, you know, he was the best embryologist in the world. He never once got 100% blast. So she's phenomenal. She's the best I've seen, and I'm really, really honored to work with her. So that has a huge thing to do with it.
You were mentioning about the egg maturity in the lab. How small can they be retrieved at and possibly be successful to mature?
Yeah, so the patient we're going to try it on does not get much past 5 or 6 millimeters. So myself and a student working with us, who's going to be doing a lot of our research for us, actually researched this the other day. And there are articles that have demonstrated that even without a trigger, you can, under high velocity suction or high pressure suction, get eggs at even 5, 6 millimeters. In fact, in that study, they were 2 and 3. So we're getting a super thin needle, and we're going to try it and see how she does. So we're going to see how that goes, but that's the only way to do it. So there are studies that have used eggs that are very small, 5, 6 millimeters, 3 millimeters. There are studies very commonly that have gone like 11 to 13 millimeters.
Does letrozole with an HCG trigger shot help reduce the chances of a miscarriage? I've had 5,
no,
and all tests came back normal.
No.
Is there anything else you would recommend?
No. So letrozole and HCG have nothing to do with miscarriage. Either does insemination. Maybe if you use that Zymo filtering device that we use, that might improve things. But there is no way that just letrozole and HCG will reduce your miscarriage rate. If you've had 5 miscarriages, first of all, my heart totally goes out to you. Please reach out to us. We will help you. I'll be happy to do it any way that I can. Even if I have to do it for free for you, at least I can talk to you about it, and I'm happy to invest that time. So I totally feel awful about patients that have to struggle through that. It's really not fair at all. So for sure, reach out to us. I'll walk you through it. But there are numerous tests that actually need to be done for us to determine why you're miscarrying. Those cheap treatments and vitamins and stuff like that, that's not the answer. It's not going to fix it. You know, it's not going to get fixed by taking this herb or that drink or this diet. That's a situation where we need to figure out what's wrong. And that's a lot of testing. So genetic testing, thrombophilia testing, infection testing, menstrual blood infection testing, hormones, thyroid antibodies, sperm DNA fragmentation, your social habits. Do you smoke? Do you drink? Do you use marijuana or any other drugs? What's your body mass index like? Like there's a ton of stuff that goes into this, and we look at every single detail, your cholesterol level, your hemoglobin A1C, your sugar control. You know, all of these things are critical. So we have to go through all of those to figure it out for you. And it's like a long list. It takes a while. We even do immune system testing for some patients. So it's not like a slam dunk, hey, go take this and you're going to be fine. You know, all the time we get patients that come in and say, I just want aspirin and progesterone. Look, I use aspirin and progesterone probably more than anybody I know. It's not going to solve every case. We need to know what's wrong. Then we can start talking to you about what to use. Yeah.
Is there any chance to get a bladder or kidney infection after an IUI?
Is there any chance? I mean, if someone stuck a dirty speculum inside of you, or you kind of were wiping around there or something, I guess theoretically, but no, I mean, we don't go anywhere near your urethra, and all of our speculums are sterilized. So I don't know about everybody else, but if you got a UTI, it was coincidental. It's not going to be something that you got from the IUI, because there's no way the catheter is going anywhere near your urethra. If your vagina is like this, the speculum is here and your urethra is there, and we are going through the middle of the speculum. So it's not even close. There's no way to infect the urethra from an IUI.
I got a question you love.
I'm going to love it. All right. The Rahi loves it question.
Unexplained fertility.
Okay.
My doc recommended the ERA, Alice and Emma tests.
No.
I know that you don't recommend ERA.
Yay.
I'm wondering if the hidden C
Yeah.
will provide the same diagnosis as Emma and Alice.
No. So Emma and Alice tests for the balance in your vaginal flora, and tells you if it's in balance or not. And I think they actually do it inside the uterus too. So one's vaginal, one's uterine. But it's just telling you the balance. The Fertility test is a little bit more sensitive in that it actually looks for the DNA of those bacteria and viruses inside the lining of your uterus. And they now give you proportions as well. So it's kind of like a more sophisticated Emma Alice. And they give you very targeted therapy. So I know what I need to treat. So it's a more sophisticated test. Emma and Alice don't do that. When the people from Genomics came to see us, they were telling me about Emma and Alice, and I said, great, this sounds wonderful. Start of the presentation, they said, we've done research. We know that what's in the vagina doesn't reflect what's in the uterus. Okay, that's great. And they said, we can test what's in the uterus. And I said, that's great too. And I said, so what do you do when there's something in there? And they said, well, we give them antibiotics. I said, okay, what do you do next? Well, we put them on probiotics. And I said, where? And they said, well, we put it in the vagina. And I said, didn't you start this presentation by telling me that what's in the vagina is not reflective of what's in the uterus? And they said, yeah. And I said, well, then how is that going to help? And literally the guy in Norway presenting, dead silent. The two women in the room with us, dead silent. They had no answer. So I really don't believe much that comes out of iGenomics. I don't think that company can stand on their scientific data, because they still say ERA works when everybody knows that it doesn't. So I'm not a huge fan. And I like the people. They're lovely people. They're all well-intentioned, but the science just doesn't back what they're doing.
Hi, Dr. Victory. I have a history of hyperplasia, which was corrected with an IUD. My IVF cycle failed. Is there any hope?
Oh God, there's loads of hope. First, make sure that your endometrial hyperplasia is corrected. And then once it's corrected, we need to figure out why you had endometrial hyperplasia. So most of the time, women with endometrial hyperplasia are going to be PCOS women who are carrying a lot of body mass. So, you need to figure out if that's part of why you failed. I would need to know about your embryo, your sperm quality. I mean, I can't answer that in terms of what's going on, but there's always hope. Look, there's very few people that we can't get pregnant. It all depends on what you're willing to put into it. And I don't mean that financially. I mean, what are your limits? Am I willing to go as far as, doing a donor, or am I willing to try multiple cycles, or am I willing to use a surrogate, or am I willing to use somebody else's sperm, or whatever, or am I just willing to lose the weight or change my dietary habits or stop smoking, or whatever the case is. So there are very, very few times where we actually cannot get somebody pregnant, as long as they're willing to kind of leave us, carte blanche with, what we need to do, and invest themselves in the process. Again, I'm not talking about money. I'm saying, if I tell you need to quit smoking, you need to quit smoking. I had a lady call me recently to say, I want to do another cycle of IVF. I said, okay. and she did terribly with her last cycle. And then I found out afterwards that even though I had explicitly told them, you must stop smoking, the husband continued to smoke. I said, no, like I literally won't do it again, because that's a waste of their money. And quite frankly, it's a waste of my time. So if you're not willing to put into your cycle what you need to do, because your cigarette or your drink or your drugs or your weight or whatever it is more important than the process, it's not going to work, guys. You're wasting your time and your money. Don't do that. Don't do that. That's not fair to you. It's not fair to your partner. It's not fair to your bank account. It's not fair to all the work you put in to make the money that you make. That's just us gouging you. And I don't do that. Like, that's totally uncool. I'd rather turn away business than do something that's dishonest or useless. Like, to me, that's the wrong kind of medicine. That's not even medicine. That's just pure business. I won't do that.
Hey, Dr. V, I had a laparoscopic surgery with you on June 30th.
Oh, awesome.
My follow-up is not until September, and I just
Okay.
want to ask, when is it safe to resume having intercourse?
Oh, never. No more sex. Sorry, no, I'm kidding. Yeah. So if it was laparoscopic surgery, I need to know what surgery I did for you. But if we didn't go in through the vagina, like you didn't have a hysterectomy or anything like that, you can have sex right away. If we did hysteroscopy, wait at least 2 weeks. And if we did do a hysterectomy, you need to wait 6 weeks.
Sessions with Dr. Victor is all I want.
Sessions with Dr. Victory is all I want. Hey, all right. You know, it's funny. Tarek and I can kind of track how many people watch. And I spend a fair amount of time preparing for this show. So we get an article and I review it. Excuse me, and I'll go over it and I'll look at everything and, you know, present. And Tarek, you know, is great at putting up our little graphs and tables and stuff. But when you watch the viewership, the part where we're presenting the article is kind of like, you know, a reasonable number of people. And then 20 minutes into the show, we see the huge spike, because that's when everybody wants to come on because they know I'm answering their questions then. So I think we'll still occasionally do an article, but probably more and more we'll either just have a guest on or we'll just jump right into questions, because I think that's what most people like.
Would you consider implanting 2 embryos in a 39-year-old woman who wants 2 children?
Would I consider it? Yes. Do I recommend it? No. And it depends on whether they're PGT tested or not. So if you have non-PGT tested embryos, absolutely 2 is reasonable. If you have PGT tested embryos, the answer is I wouldn't. And here's why. You have a very high chance of getting pregnant with twins. Twins carries increased risks of every single complication: miscarriage, stillbirth, preterm labor, preterm delivery, premature rupture of membranes, high blood pressure, diabetes, need for cesarean section, wound complications, like every single complication. And if you deliver your babies really early, those babies are now at risk of an enormous number of problems. So we don't recommend it. Even if you make it through all that stuff, it's an 80% divorce rate. So we never recommend aiming for twins. If you want 2 kids, have one. You can virtually almost immediately have another, but don't do it at the same time. It really does complicate things. Age plays a role. I get it, you know, especially if your partner is older. So we're always willing to have the discussion, but we never push it. Never. We always put in 1 at a time. At least I always put in 1 at a time. I have colleagues that do more, and that's fine if they're comfortable with that. But, you know, it depends on how many you want to put in and what your expectations are.
There's a huge rebellion happening on Instagram.
Oh, no, what's happening?
No, it's not a bad rebellion. They're just like, what does Tarek look like? We need a face to the voice. And then somebody else like, for real, show us his face. And then someone else is like, he's like the man from the Wizard of Oz. He's like the man behind the curtain.
He's the Stig, if you ever watched the car show. We're going to bring him out in a helmet so no one ever sees what he looks like.
What percent of embryos will be normal at the age of 36, 37 in October? Thank you.
Just over 50% will be not normal. At 35, 50% are not normal. If you guys watch our video on YouTube called Embryo Math, there is a graph on there that shows you, based on your age, what your percentages of aneuploidy are. It's readily visible in that video. So go on YouTube. It's our highest viewed video. It's got 45,000 views, something like that. It's called Embryo Math. So I think I'm in a dark shirt on the front of it or something like that. So very handsome. Thanks. Yeah, I wish. So take a look at that and watch that video. It's hugely important for you because you'll understand the numbers and you can see where this study is from. Are we winding it down? 9:10.
We should.
5 more minutes?
Sure.
All right. 5 more minutes, folks. Get your questions in quick.
That's good. How does baby aspirin help in FET? Can I take anything starting when I do my FET to increase chances of implantation and success?
Baby aspirin helps by decreasing inflammation, increasing blood flow, improving oxygenation, reducing your risk of preeclampsia, reducing risk of preterm labor, like it goes on and on and on. What can you take? Okay, vitamin D, omega-3 fish oils, melatonin, all proven to be beneficial. We use letrozole prior, but you have to do that at the right time. Don't take it in the middle of your cycle or it'll epically mess everything up. Take as little estrogen as possible, ideally none. Use both vaginal and progesterone in oil. So vaginal progesterone and progesterone in oil. Acupuncture, if you believe in it and it helps relax you. I think that's everything I got. Yeah, do all of those things. Those will help. A lot of people are asking us about our FET protocol because like our numbers are off the charts as far as success. They really are crazy good. So I'm happy to share. Like, I don't want to hide it. It's not something we make a secret out of. So I like telling people one-on-one, but just grab us and we'll share it with you and we'll tell you what we do.
Where did it go? Yeah. Saw your video on male fertility.
Oh, awesome. Hey, we just got that up. We have a great male fertility video.
Hubby does agree with you on ejaculating every 2 days, as that could deplete energy and nutrients from the body. What are your thoughts?
Oh, he doesn't agree with me.
She wrote does, but she must have.
She must have meant doesn't.
Yeah, must have wanted doesn't.
Well, you can tell hubby he hasn't read the science, I guess. I don't know what to say. Yeah, that's not true. There's no depletion of nutrients or energy from the body. In fact, there are studies that show that around ovulation, it should be every day for several days. So we recommend every 2 days and then every day right around ovulation for about 3 or 4 days. Yeah, and that's science. Like, there are lots of studies on this. So if he says that's not the right thing, then he's not following the science. Like Dr. Fauci.
Yes. Is a BMI of 18 with regular ovulation each month and no other issues a problem for fertility? Yes,
that's underweight. And so you will have a harder time getting pregnant. You need to take on a lot of calories and add on some fat. This is a frequent discussion. It's particularly hard in the summertime when women and men want to look good in less clothing than they're in the wintertime, especially if you're in a bathing suit, a bikini. But it's not good for fertility. Your body needs a certain amount of body fat, in particular as a woman, for your hormones to function normally. If you don't have enough, your chances are reduced. And there's so many studies on that. There's probably 100. So women with low BMI have a harder time getting pregnant than women with a normal BMI.
Can you take Clomid too many months in a row?
So Clomid can cause cysts. So in that regard, possibly. And there was an ancient study from 60 or 70, that I think it was 60, that showed that women that took Clomid for 12 months in a row had a higher risk of ovarian cancer. So for years and years, we weren't using Clomid for more than a couple of times. Having said that, very few people should be on Clomid now, because head-to-head, letrozole is much better than Clomid is, and so you should be on letrozole. If you fail letrozole, you can take Clomid a few times, but if you failed after a few times, it's time to move on to shots. Don't keep taking Clomid. One more?
Sure.
Tarek's terminal question?
Oh, I already showed it to the audience, so I think it might be too late.
All right.
We'll see. Just an idea.
Okay.
But it would be helpful to see a poster video on efficacy of FET add-ons. HCG, wash, neopogen, steroid, scratch, antihistamines, embryo glue, interlipids, IVIG, etc.?
Whoa, you know what? That's too much to do in one video. Although we have videos on those things, I can talk to you about some of them. So IVIG, there's no evidence. Subcutaneous IG, well, there is some evidence for IVIG, but it's controversial. Neupogen, there is some evidence, but only if you have a thin lining, or if they put it into your egg culture media, then it can help as well. Embryo glue, we've done that on the show. It does show a benefit. HCG wash, it does show a benefit. What was the other one? I think I got them all.
Steroids?
Steroids, probably beneficial. There are studies back and forth, but overall it looks beneficial.
Antihistamines?
No evidence. There is no evidence that antihistamines are beneficial. What else? I think that was
Scratch?
the endometrial scratch, the most controversial topic in infertility. I don't think it helps. So I don't do it anymore. There are enough studies that have said it doesn't help, that it doesn't make sense to do it anymore, but it constantly goes back and forth. Constantly. It's literally the most controversial topic. So every month there's a study that says it doesn't, and then the next month there's a study that says it does.
Is there any disadvantages or considerations for seeking treatment with you remotely? I'm located in the GTA.
Not at all. In fact, I have an office in the GTA and can see you. And we have patients seeing us from Australia, from Japan, from Russia, from all over Europe. I have a patient in Africa. It's not a problem. Anywhere you are, we can help you out.
You want one more? Is that what it is?
No, I think we're good.
Okay.
That was a good ender question. All right, guys. So we are super thrilled, as always, to have you on board. I think we're going to start doing more polls and votes and stuff like that on Instagram. So watch for the Instagram. Go on YouTube and make sure you watch some of those videos, especially Embryo Math. If you are considering doing IVF, no one should do IVF without watching that video. It's so important for you to understand what your numbers are going to be. Best wishes to all. Congrats to all of our amazing patients that have warriored through, and all those of you who have successfully become pregnant. And we'll talk to you all soon. Good luck, guys. Have a great night, and we'll see you next week.